So we'll start. Good afternoon or good morning, dear colleagues. Welcome to this IAAP webinar. It's a great pleasure to have this opportunity to moderate this webinar on mortality, migration, and mental health, translation to action. My name is Yixun Gan from Peking University, China. I'm also the president-elect of Division 8 IAP. And first, please allow me to introduce our honorable panelists. Our first speaker, Brian Hall, is a professor at New York University, Shanghai. Our second speaker, Danhua Lin, is a professor in Beijing Normal University, China. Our third speaker, Sita Patel, is a professor at Palo Alto University, USA. Our fourth speaker, John de Wit, is a professor at Utrecht University, Netherlands, but unfortunately, due to his limited working environment, because he's working in Thailand, so he's not able to join us. So that is very unfortunate. But I believe that all of our guests are top experts in this area. And finally, the president of the Division 8 IAP, Sonja Lipke, professor at Jakob University, Bremen, Germany, will be concluding this discussion. Next, I will briefly introduce the background of this webinar. According to the official statistics, there are nearly 1 billion international or domestic migrants every year. So mobility or migration is a social issue of great concern to the public. Migrants today may face many challenges that are harmful to their mental health. However, this topic has not been studied a lot in the field of psychology. As co-editor-in-chief of Applied Psychology, Health and Well-being, my colleagues and I have organized a special issue to increase our understanding of this problem. This special issue, which will be published probably in June or in the fourth issue, will examine the innovative research methods and interpretations of public policies and interventions. Our webinar intends to start and stimulate the dialogue on global migration and mental health. We have invited two guest editors, Brian and Danhua, and authors from the special issue, along with the board members of the IAAP Division 8 to join us at the webinar. So instead of being formal presentations, we plan to make it a roundtable forum where we can talk freely on several topics. And I think we have less time constraint today because one speaker is unable to join us. So overall, the goal of this roundtable discussion in this webinar is to discuss important issues related to mobility, migration, and mental health worldwide. We aim to share and enhance our understanding of the related psychological and behavior research and practice, and facilitate efforts to further develop practice and responsive programs and policies that reflect current science. So the discussion will focus on 3 topics, and now it might be 2 topics, but the third topic, I think, although our speaker cannot address it, the audience can keep open to discuss it. The first topic is, what are the key risk and protective factors that mediate or moderate the effect of migration on health of migrants? And the second topic is how to conduct and evaluate effective interventions to improve migrants' physical and the mental health. And the third topic is what gaps exist in our knowledge about migration, mobility, and health. So we'll start from the first topic. So Brian, would you like to take the lead?
Thanks, Professor Gan.
Yeah, I will continue. I will share my PPT, pause share, and yeah, right. So you can share your PPT, right?
Great, thank you very much.
Oh, that's great.
Okay, yeah. So thanks very much for having me on this panel this evening. It's really a pleasure and honor to be here. I just want to start off by talking about migration as one of the defining global issues of our time. The Lancet Commission on Mental Health and Migration had mentioned that distressed migration in particular, or economic migration, puts migrant workers at particular risk of unsafe transit and pressures, sometimes with coercion to engage in unsafe work conditions. Low wage labor migration is also closely linked to globalization and supply and demand, especially for cheap labor, which increases vulnerability for populations on the move. It specifically focuses our attention on the social determinants of health. And the social determinants of health are, they reflect the social factors and the physical conditions and the environment in which we are born, live, work, play, and age. And we see here in this diagram that there are various concentric factors that influence our health and well-being, and particularly will influence the health and well-being of migrants. And that is individual lifestyle factors, social and community networks, and the living and working conditions that are consequential to our health. The larger general socioeconomic, cultural, and environmental conditions are also important. And specifically for migrant workers, taking a perspective of decent work from the International Labor Organization, decent work are opportunities for men and women to obtain decent and productive working conditions of freedom, equity, security, and human dignity. And this is directly related, again, to these various social factors and determinants. We've done a lot of work in China and Macau, in particular, focused on migrant domestic workers from the Philippines and Indonesia. And in our study with Filipino domestic workers, we really tried to center our work on understanding what social determinants of health and well-being would be consequential, both from a epidemiologic perspective and understanding these risk and protective factors, but then also to motivate potential interventions. We looked at a variety of factors through a qualitative approach. So I think that, engaging in mixed methods research, specifically among migrant or populations where researchers themselves aren't maybe a member of the population, it's really important to kind of contextualize the research agenda from the perspective of the migrant workers themselves. And so we engaged in ethnographic field work and qualitative investigation to really understand what the various determinants of their health might be, and also to understand what those health related factors are. And so we looked at things related to the social and community networks, including family relationships and peers, as we know that migrant workers who live abroad continue to maintain ties and relationships with families back home, but sometimes these ties can be fraught with various challenges, including issues with romantic relationships and infidelity, or raising children from a transnational perspective. We also know that social relationships with peers can be potentially difficult to maintain as well, especially when individuals are undergoing various pressures and demands in a host country. Working and living conditions, including the working environment, access to healthcare services, and housing are also important factors that we identified in this population. And the cultural and policy environment, including issues related to employment agencies, inadequate labor protections, and larger geopolitical concerns were also important, as are issues related to discrimination that are experienced both by individuals of the same community, but then also of the host community. We looked at this research and tried to understand these various risk factors and identify their individual association with mental health outcomes. And so In terms of financial strains and difficulties, we looked at the context of remittances, having sufficient amount of resources, financial resources, also the number of dependents that were relying on them, and the indebtedness. And we found that individuals that that did not have sufficient amount of financial resources and also found themselves in debt had a higher odds of depression. As a part, it's RDS weighted, meaning that it's a respondent-driven sampling study. So it's a pseudo-representative epidemiologic study of domestic workers, and this is representative of about 1,400 women. We also looked at the housing environment. We looked at issues related to, sleeping in the same room, so co-sleeping with people they're caring for, like elders or children, having enough privacy, feeling uncomfortable, or being in noisy environments. We found that if they stayed with their employer and they were in an uncomfortable environment, or the environment was noisy, it increased the odds of having depression. And if they stayed in a boarding house or outside of their employer's house, and noisiness and disruption in their living condition, in their living environment, was consequential to depression. In terms of social environment, we saw that social conflict increased the odds of depression. We also looked at cognitive and structural social capital. And the interesting thing about this finding is that cognitive social capital was protective, and that is believing that you're a part of a community that's trustworthy and reliable, and there's reciprocal bonds and ties. Whereas a structural social capital actually was associated with an increased odds of having depression. And we interpret this as in structural social capital is really about the number of groups that a person is a member of and activities they engage in with other members of the community. And we interpret that as being a part of a community that is also experiencing various stressors and trying to cope together. Looking at the working environment, of course, not having sufficient days off was something we looked at, but it wasn't important associated with mental health. But experiencing verbal abuse or being fearful of terminations or not being treated as a member of the family for migrant domestic workers was all associated with increased odds of depression. In terms of the cultural environment, we did find that discrimination by locals and by other Filipino workers was also important and associated with an increased odds of depression. I just want to close this, and I went very quickly because we don't have much time, but I just wanted to say that we should also be mindful of keeping traumatic stress in our thoughts about cumulative exposures. So exposures to trauma and stress actually occur before migration actually takes place, during transit, and at the destination phase. And in the destination phase, we see there are other consequential exposures: discrimination, lack of integration in the host country and population, loneliness, various stressors, and also ongoing exposures to either traumatic stresses they're experiencing as a part of their labor or that are occurring to family members back home. And we have to keep this in mind when we're doing research on migrant populations. I will conclude there. Thanks.
Okay, I believe I'm next. All right, thank you, Brian, and thanks for having me. I'm very happy to talk to you a little bit about the context currently in the United States, and in particular, migrants living in the San Francisco Bay Area, which is where I'm located. So these are the questions that we're addressing. So I'll start with the first one. So what are key risk and protective factors that mediate or moderate the effect of migration on health among migrants? And, this slide really reminds me a lot of what Brian was talking about. And I often refer back to this as just a sort of reminder of how many factors are really impacting migrant families. So as Brian was discussing, there are a number of factors that may play a role in the migration experience, the adaptation, and the capacity to thrive post-migration that happen before the migrant even leaves their home country, during the migration journey, and then following migration. And a lot of the folks in our research right now are from Central America, and a lot of my work is with youth. And so, a lot of the kids in our studies have this pattern of risk factors, and sometimes more. But, the idea, I think, with any consideration of risk is that I sometimes think of it as 1 + 1 doesn't equal 2, but 1 + 1 might equal 10. So the impact of more than one risk factor can really have an exponential impact on the well-being of migrant youth. So I wanted to anchor us in just thinking about the fact that migration, worldwide, but certainly in the United States, is something that's been happening for many, many years. And yet at the same time, we're always needing to think about the current context. So today, especially in the United States, with migration policies that have been very restrictive in recent years and are evolving a bit now, it's really a unique context. And so whenever we think about what kinds of risk factors are present for an individual, we have to put that within a contextual framework. I love this as kind of a really vivid illustration of how migration policies impact who is moving around the world at a given time. So if you look at the years down below, you can see to the United States where we are receiving migrant populations. And the colors represent different countries, and you can see at certain times there were very low numbers of migrants, and at other times there were much larger numbers and from certain countries and regions in the world. So again, context really makes a difference in thinking about who is coming, the host conditions, and the risk factors that people are experiencing. So right now, Central America is sending the highest number of child refugees to the United States. This gives a sense of where kids are coming from, which cities within Central America. And when I say Central America, I'm referring to Guatemala, El Salvador, and Honduras primarily. And a lot of the kids who are coming are unaccompanied. So they are sent either following their parent who had maybe migrated years prior, or they're sent on their own and their parent stays in their country of origin. So 75% of unaccompanied minors currently coming into the United States are from Central America. If we include Mexico, then 99% of unaccompanied minors are from those regions. So even beyond unaccompanied minors, Central Americans are the largest group of asylum seekers in the United States currently. And, there's been a lot in the media, not only in the past several years, but really just in the last few months. In 2021, over 47,000 unaccompanied children have been detained at the border. And this is a 163% rise from this same time last year. So the numbers are just staggering. And I feel like we say that every year, but it sort of increases so exponentially each year. And again, all of those kids who are coming are received and their experience is shaped by these different migration policies over the years. So currently, some of our research is looking at the experience of detainment and family separation and some of the things that are happening right, when they arrive at the border. So our policies have been quite restrictive in the past several years, and now there's a lot of dialogue around how are we going to grapple with these large numbers of people who are coming, and how can we adapt policy to really meet the mental health and humanitarian needs of folks coming. So just briefly, one of our studies that we published this past year was looking at family separation and reunification experiences among unaccompanied adolescent migrants from Central America. And I want to offer this just sort of tidbit from the broader results. It's a qualitative study, but I really think we need to expand our perspective on family separation. So we've done some research already on the impact of family separation. But what we found in our research is that the family separations are much more complex than just a separation between a parent and a child. Often these are kids who have had multiple separations. So a common story would be something like a parent migrating at some point, and then maybe 10 years later, the child comes, and they maybe travel with their sibling, and then along the way or at the border, they're separated forcibly from their sibling. They maybe were raised by a grandparent, and so they're experiencing an attachment disruption and separation from the grandparent. And so this quote on the left was one of our participants who said, "I was separated from my brother for a month when I came to the United States. I felt bad because I wanted to know what was going on with my brother, but no one would tell me anything. I also felt fear that I would get sent back to my hometown." So again, I think we need to think more broadly than just a parent-child single separation. These are families who often function from a more collectivist perspective. And so the attachment relationships may be between a child and grandparent, a child and aunts and uncles, a child and their siblings, and they're experiencing multiple iterative kinds of traumas in these separations. And then the second piece that I encourage us to think more about is the reunification process can actually be really complicated and pretty challenging for kids who have had really prolonged separations from their parents. So again, a very common narrative was kids whose parents had left, migrated 10 years prior to them. And so they're reunifying sometimes with their parent in the United States, but they weren't really raised by that parent. And so they're, we had these narratives around feeling like a stranger and not feeling connected, and there being conflict in the family following the reunification. And the quote on the right says, "I don't get along very well with my mom and dad because I didn't grow up with them. And it's like, I don't have affection for them because I grew up with my grandmother." So again, we really need to think more broadly about family separations, about who is being separated and what the impact of multiple separations is, and how we can support families who are reunifying when that is a complicated dynamic. So I think this research has a number of implications for actions that we can take on the policy level. I think we really need to be thinking more about the psychosocial burden of prolonged separations and the complexity of reunifications. From a clinical perspective, we need to have our interventions be both trauma and contextually informed. So again, we're in a unique context right now, and the risk factors that we need to address need to be informed by that context. And then when you come back to me, I'll speak more about program development and how we can best develop school-based and family-focused mental health programming. So again, I will return and answer those questions. Thank you.
It's my turn. Professor Gan, you...
Yuchen, you are muted. We can't hear you.
Yeah.
Oh, sorry. So thank you so much, Sita, for your very rich for information and very insightful opinions. And next, Danhua will share with us the second question, the second topic. Yeah, please.
Thank you, Professor Gan. And my presentation topic is about how to design and develop theory and evidence-based health promotion programs among migrant population. So let's look at the number of migration-related population in China. So we can find out several statistics. According to Chinese Ministry of Civil Affairs, there are 6.97 million left behind children in 2018. And we have 35.26 million rural to urban migrant children in 2015, according to Chinese Ministry of Education. And we also have 120 million young rural to urban migrant population who is under 40 years old, according to National Bureau of Statistics of China in 2020. So how can we design and develop a theory and practice evidence-based prevention intervention for the population? And we think 6 steps are urgently needed. One is the need assessment and identify the at-risk migrant population, quality of life, and the health problems. The second step is about the definition of performance and change objectives based upon scientific analysis of health problems and problem-causing factors. And the third step is very important. We should select the important related theory and find out the evidence-based intervention methods and practical applications to change health-related behaviors. And step 4 is about the production of program components and design and the production of the program. And in the fifth step, we should conduct the program implementation. And the last step is about the evaluation of the prevention intervention program. So we can see the whole prevention intervention process includes 3 phases. One is the preparation phase, second is design phase, and the third is implementation evaluation phase. So in the first phase, we should conduct several needs assessment and identify the population, identify the goal and outcome. And the design phase, we still focus on the theory to select the important theory and develop intervention program and design the whole intervention process. So in the third phase, we can conduct a baseline survey and conduct intervention implementation and evaluate the effectiveness of intervention. Regarding the theory, we can find out several important theories such as health belief model, protection motivation theory, TPB theory, TTM, HAPA theory, etc. So which theory is can we select depends on the outcome or we want to change and the population. But anyway, theory is the most important. And regarding the evaluation methods, we can use a lot of innovative methods. For example, we can use quantitative assessment to evaluate the short-term and or long-term intervention effect. And we can also use qualitative assessment. For example, we can use process evaluation to evaluate the intervention in the middle and end of the intervention. Besides questionnaire, the psychosocial measurement, we can also use some objective biological measurement. For example, salivary cortisol or brain structure, brain network. We can find out whether the cortisol concentration or some gray structure or rest brain network will be changed after the prevention intervention. And we can also conduct process evaluation and summary evaluation as well. And now I just want to share 2 examples of theory-based mental health prevention intervention among rural to urban migrants in China. So from the example, we can find theory, acculturation, mental health, rural to urban migrants are the keywords. So we can find several important theory related to the outcome and the population. Because our population is rural to urban migrants, so acculturation, stress, and the coping model, which is developed by Barry in 1997, is selected as important theory. And we can also find out some important evidence from some study conducted in China. For example, from the study, we can find some important influencing factors. For example, discriminatory experience, social stigma, expectation, reality discrepancy, coping skills are also important protective or risk factors related to rural to urban migrants, quality of life, and psychological distress. So these are the very important influencing factors related to their mental health. And we can also find out several other important theories, just like the acculturation strategies to identify their identity, which is developed by Berry. And another important theory is about the comprehensive acculturation model, which is developed by Ward in 2001. So from the model, we can find several important factors related to psychological outcomes or social-cultural outcomes. For example, the stress, the skills deficit, and coping is the most important component. So we can select all of the important components in our prevention intervention program. So in the programs, the program includes 7 sessions. Session 1 is group building. Session 2 focuses on emotional regulation under the acculturative stress. Session 3, we consider the expectation reality discrepancy, which is the important factor related to the mental health of the rural to urban migrants. And the session 4 and the session 5 focus on stigma coping. One is focus on cultural identity, the other is communication skills. And session 6 focus on interpersonal relational skills. And session 7 focus on social support seeking. So we can find such a prevention intervention program is suitable to rural to urban migrants because we developed the program based on theory and evidence-based. We find out the core and important factors related to their mental health, and we change it into the important intervention components. And I like to share an example to all of you.
Maybe,
That is
maybe next time, Dahua.
okay.
Of the time limit.
Okay.
So you
I just 1 minute.
Yeah.
Okay. So the example 2 is the protection motivation theory, and we also find very good intervention effectiveness. It greatly reduced their condom, increase their condom use and increase their knowledge. And okay, future direction. Moreover, an appropriate methodological approach should be used to conduct the theory and evidence-based intervention among the population. And interdisciplinary research and intervention program could be influential through well-defined integration of ideal concepts to explore research questions pertinent to the links between health and migration. And it is urgently to translate cutting-edge findings of multidisciplinary research into policy intervention and other best practice to facilitate and improve migrants' health and well-being. Okay, thank you very much.
Thank you so much, Dahua, for sharing with us a very insightful approach and very rich information. Okay, so Sita, would you please share your opinion just a little bit short? Yeah.
Yes. So I'm going to turn now to the second question that we're thinking about together today. So how do we go about conducting effective interventions to improve migrants' physical and mental health? And I think what was just said is a really great springboard for us to think about in terms of developing programs that help folks with those different components: emotion regulation, expectations, stigma, relationships, and support seeking. So I'm going to focus on a couple of those as well. And I thought I'd start us with this slide to kind of anchor our thinking about how we consider interventions and preventive work and where our resources can go. So There are more resources needed along the bottom of the pyramid, basic services and security, and following up community and family supports, and then specialized services for PTSD and other kinds of concerns are really the top of that pyramid in terms of what's recommended. So I'm going to talk briefly about two examples that I'm involved in. One is a school-based preventive intervention that it was designed for newcomer migrant youth. So these are folks who are in the first phases of post-migration and acculturation. They are in the school system in the San Francisco Bay Area. It's called the Fuerte program, and it's a partnership among a lot of different individuals, including at UCSF and the San Francisco Department of Public Health. So this is an evidence-based program based on the ARC model and CBT skills. The components include collaboration. It's an innovative service delivery model in that we are in the school system. So we go to the schools, we use a trauma-informed lens. And, we, of course, with school closures in the United States following the pandemic, we had to quickly adapt this to be an online modality. So the idea is that it's in a school, but this past year we've been doing the programs online. We thought a lot about how to be innovative and adapt this for the population that we're working with. And again, given the current context, so the program is conducted in Spanish in order to reach more Latinx youth. We adapted it to then, as a later phase, be carried out with additional populations beyond Latinx immigrants. And our idea is that we'd like to really kind of spread this throughout California as a resource. So again, a brief modality, it's 6 sessions, and we'd like to increase access to mental health. So some of the key goals are for the youth who participate to be able to identify when they have mental health concerns that need support and how to reach out for those. So the second program that I'll speak briefly about is a program called Soccer Without Borders. And I was involved in doing a program evaluation for this program in Oakland International High School. This is throughout the world, they have this program. And the idea really, I think, is so important given the context of what I spoke about earlier and the relationship disruptions that a lot of migrant youth have. So in the context of having multiple family separations and grappling with that, other kinds of positive relationships can become so important as a protective factor. And so this program really helps to foster those. So the relationships that are strengthened are with peers, are with coaches who end up serving as mentors, and other really strong adult kind of relationships for the kids. And it really helps them through this sport to develop both individually and to kind of hone their coping strategies. So it's been a really wonderful program for a lot of youth. The evaluation that we did showed that it was very effective, and that was the component that was most effective as a protective mechanism was the social relationships, in particular the social relationships with these adults who play a really important role in the kids' lives. So again, coming back to these key questions, one of the key risk factors that I think is so important is the disruption among family relationships. And again, those are complex. It's much broader than just a parent-child separation. And then one of the key buffers that we can think about are those social supports and really building those relationships beyond the family in order to strengthen a child's attachments and well-being. And in terms of how to conduct effective interventions, the 2 examples that I shared, one key component is that they are accessible. So kids are in schools, and if we can deliver interventions in those settings where the kids already are, then they are most accessible. They're also very efficient. So the Fuerte program is 6 sessions, and it really condenses larger ideas into those 6 sessions so that kids can really be informed about their mental health and when to seek services. And I said appealing and adaptable, we really have to think about the context that kids are operating within and what will they want to engage in. And so again, we quickly transitioned to an online platform following the pandemic. And we navigated a number of sort of challenges around that, but what we maintained the program as something that was adaptable and accessible to them. So in conclusion, I think we need to think quite a bit about how policy impacts our social context and how those factors shape the nature of risk factors that immigrant families and children are facing. In the context of the United States, we have a surge of Central American unaccompanied minors who are entering the United States, and we need to think about psychosocial programs that are contextually adapted in order to address the very complex trauma and multiple stressors that they are faced with. And most importantly, for developing these kinds of programs and understanding the experience of migrants are the development of frontlines partnerships. So all of my work happens in conjunction with clinics, with community agencies, and with schools, which is where the migrants are, and really using the voices of those agencies in collaboration with the empirical perspective to help address this urgent humanitarian crisis at our border. Okay, thank you.
Okay, thank you so much, Sita, again, for bringing us so appealing programs. So next, Brian, would you like to add some opinion, but be a little bit shorter than expected? You need to unmute yourself.
Okay. All
Okay.
right. I'll try that
Okay,
again.
thank you.
Yeah, I will try to be concise with this and make a few additional points to the great points that Sita just made. So I just wanted to highlight in my presentation that we should start with qualitative informative work. And I think for folks that are doing work with migrant populations and attempting to design and develop and adapt interventions, this is kind of goes without saying, but I think it's really important to go beyond just a qualitative exercise, but then also to engage in ethnographic work and community stakeholder partnerships and events and consultations in order to in order to build partnerships that will serve as a foundation for sustainable research engagement with the community. And this can lead to more formal qualitative interviews and more a deeper community needs assessment informed by local perspectives. The work that we had done again with migrant workers in Macau, through this process of consultation and this ethnographic field work and getting to know labor migrants personally, we were able to gain trust and rapport in the community to identify modifiable health issues. So those modifiable health issues went beyond just mental health. We did find that depression, exposure to workplace and other potentially traumatic events, post-traumatic stress disorder as a consequence, gambling, alcohol misuse, were all important things to think about and address. We also identified obesity and hypertension. So I think we often forget that populations are complex and their health-related issues are comorbid. So there's issues of multimorbidity. Individuals with a physical health-related problem might also have a mental health-related issue, and vice versa. We also identified issues related to social support, as Sita mentioned, as a key area as a protective factor. And we also looked at issues related to sexual health, so sexually transmitted infection, partner infidelity, leaving women vulnerable to experience STIs, and also poor testing and uptake of sexual health services in the community, furthering their vulnerability, and general poor access to health services. So through this community engagement, we were able to identify key barriers to access to care and also key areas that the community themselves had voiced concern about and things that they wanted to be addressed. I think it's important to select an intervention that can address one or more treatment targets. And Sita had presented a slide from the Interagency Standing Committee that showed a pyramid of services. And the pyramid of services had individual mental health supports with specialists as being the very top of that pyramid. But when we're thinking about migrant populations, our approach is to also think about scalable interventions that can address the needs of the majority of the population. Because although we know that depression and common mental disorders are issues that are affecting a large proportion of the population, not everyone in the community will require a specialist mental health provider to deliver the treatment that might be needed. So the World Health Organization was working on issues of, working on scalable intervention programs. And one program that they had developed was a program called Step by Step, which is a depression-oriented intervention based on behavioral activation. And we know that from the research literature that behavioral activation could also have effects on other mental health issues like anxiety and post-traumatic stress, and particularly delivered on a digital mental health platform, so a mobile application, had the potential of reaching a large number of people. And so we did an evaluation in our epidemiologic study to understand, again, from the community perspective, if mental health services were something they thought was important, and 75% said it was essential, and 66% said they would make use of free services if they were available, and importantly, 91% owned a smartphone. We also asked what type of treatment they would appreciate or prefer, and 27% said they would participate in a 5-session weekly in-person treatment, compared to about 65% that said they would use a web-based or online treatment. So it gave us some evidence and some support to move forward with a digital intervention. I want to also highlight the importance of cultural adaptation. In all the interventions that we're doing with migrant populations, we have to take into consideration their unique cultural background and ensure that the programs that we're developing are systematically modified in order to reach their needs. And in terms of cultural adaptation, we basically focus on these 3 areas of relevance, so that it's intervention content and the program itself is related to the cultural group, that it's acceptable, so that nothing will be offensive to the cultural group, and also comprehensible, so that it can be easily understood, not just from a linguistic perspective, but also from a perspective of including particular idioms or expressions that are comprehensible in the content. In order to carry this process out, I just wanted to use this as an example. In the adaptation of the step-by-step program from the World Health Organization for Filipino overseas workers, we went through a process of adaptation where we first engaged Filipino psychologists who had extensive backgrounds and experience in working with migrant workers to gain their perspectives to initially adapt the intervention content and material. And then we went through a series of iterations of adaptations of the content, the stories, and the illustrations and text with migrant workers themselves. So we had focus group discussions with men and women who were purposefully sampled to represent elements of the community, so that they could voice those concerns and help us to adapt the materials. Just as a way of example, there were a few different adaptations that were made. For example, in this slide, we're looking at activities. So behavioral activation relies on activities that a population would engage in. In the original story, which was originally adapted for the Lebanon context and Syrian refugees in particular, they were planting herbs and having a family reunion. But in the Macau context and in China, migrant workers don't have the opportunity in many cases to see family members or have enough space to plant herbs and have a garden. And so we adapted the material to show them, at historic sites or singing videoke with friends, which were suggested by the population themselves. And again, for the content in terms of relevance, we wanted to make sure we adapted the stressors that might cause or lead to mental health issues, and adapt them particularly for the populations that was resonant with them. And in terms of acceptability, we had feedback both from the Filipino expert psychologists and also from the community themselves that the original character that we had showed them, which was a physician character who would guide them through the intervention and give them various lessons about content in terms of how to adjust and adapt to being a migrant worker, they felt like those characters were stigmatizing. They didn't want a physician character to talk about mental health. And so instead, we adapted the intervention to have senior characters that were themselves successful migrant workers who could serve as role models for our intervention program. And we also changed the entire goal of the program, rather than to cope with difficult emotions and problems, but instead to have them become more successful overseas Filipino workers for their family's sake, because the identity that Filipino workers had expressed was one of important sacrifice for their families back home. I just want to end by saying that it's really important, again, to build these community-based partnerships. And in Macau, it was really important that we had, Macau Caritas, which is a very well-respected NGO that was community-facing and did a lot of work with migrant workers, but also community members themselves, so members of the Philippine migrant worker community, to help us to inform the work that we're doing, but also keep us on track to make sure that we're doing work that is relevant to the population. Also priests, consulate, government members of the government, and university researchers. So it's really important, I think, to have multiple perspectives and stakeholders to really inform the work we're doing with migrant workers. So that's what I have. Thank you.
Okay, thank you so much, Brian, for your very informative and terrific talk. And we have received one question. So Brian, would you like to briefly answer this question? I think this is to you. To what extent is the UNHCR implementing these physical and mental health interventions in KG refugee camp in Ujeda, where many South refugees are hosted? I think this is the question, Susita, right? Susita, would you like to answer this question shortly?
I wish I had an answer for you. I don't know the answer to that. I think, I think refugee camps are a unique context to deliver any kind of intervention. And so I think that, that's the main thing that I would offer, is that there's a great need for intervention in refugee camps in Uganda and elsewhere. And, the other thing, some of my work is also in the Central African Republic, and we also need to be thinking about internally displaced migrants. So I think, the interventions that the UNHCR are recommending have applicability in a lot of different contexts, both internal displacement.
Thank you very much, Sita.
Yeah.
Yeah. And sorry, we have no time for other questions because I didn't expect that our speakers are so active and giving so much information that actually we are very excited about this information, but yet we have no time to discuss about it. Okay, so let's welcome our president, Sonia, to conclude this discussion.
Okay, thank you very much. So also a great applause to the presenters and their very important developments and just exciting findings. I think these findings are really inspiring to also.
Sonia, your voice is a little bit trembling.
You don't hear me?
Adjust it a little bit. Do you think the others? Yeah, I can hear you very well.
Can you hear me?
Yeah, very clear.
Okay, so I would like to engage now the audience as well to also give their feedback. So one of the discussion question was, what are the key protective factors that mediate or moderate the effect of migration on the health of migrants, either on basis of your own research or what you just learned from the presenters. I would like you to now indicate your own opinion. You can do that by going to menti.com. So just open a new browser window and go to this web page, and you need to type in the code 21768505, and then you can give your own answer regarding these different aspects. So I could elaborate a lot more about the findings from the presenters. I was really excited to see the different theories and models, how you use those models to inform your interventions, to not just research what is out there, but also to actually, test how we can help individuals to actually improve. And I now see that some of you are participating in this exercise, giving some indications of your own ideas.
This is amazing.
But I expect more people to participate in this because I see that there are 32 participants. I now have 6 answers, and maybe we can gather some more. And actually, to make you aware of the timing effect, please hurry up because there will be 2 more answers, 2 more questions.
Yeah.
And I invite everyone to give answers to those questions as well. Okay, but what we see here is that one important factor that stands out is social support in general. All the different aspects seem to be important, but multi-level interventions is the key aspect here. And I would totally agree that what we learned is that it's not just that we should look at migration itself, but also the stress risk factors. Okay, so let's move on. I open the next question. How to conduct and evaluate effective interventions to improve migrants' physical and mental health? What do you think? Should we apply minority stress model or theory? Should we rather perform cultural adaptation? Should we run RCTs like Danua has provided us some insights in, and should we disseminate our results appropriately as we do it with this webinar today? And you can give a rating.
The audience would like you to repeat the code.
Oh, the code is shown here in the beginning. It's 21768505. And I asked Courtney to also give the link just to enable everyone to log in quickly.
Okay, thank you.
Courtney, can you maybe post the link again, because it seems a bit difficult to actually access the link. Okay, thank you very much. And we see now the majority of the answers fall into the category of a cultural adaptation. I would definitely agree with that. But apply minority stress theory is also important, or other theories, yes, definitely. But in general, all of those different aspects are important. And that's why I would now like to invite you to identify the gaps which you may still see in our knowledge about migration, mobility, and health. So here you are welcome to just type in some words, and any word is welcome. There are no right or wrong answers. Everything is welcome. Please. Can you see the question actually? Okay,
I
good.
cannot see the question. We cannot see the question on the screen, but maybe they can see it on the net, on the web net.
You cannot see the question here? This
can
is
see the
very
question
strange.
here, but not the blank for the word. Yeah, here we can see it right now.
Yeah, well, I actually need you to type in something. So
Oh,
it's
I see,
really a
right.
question to the audience to participate here. I see that 3 people participated, and the larger the words actually are, the more people have indicated that. So lack of cultural adapt is something that more than one person has named, and we see other factors. Okay, and I see now very different aspects which should be taken into consideration, also like technology and scalability. I totally agree to that. This also relates to the current effects of the COVID-19 pandemic. And we see that there are different aspects which we did not have the time to talk about today. So as the time is almost up, I think we have to follow up on this session, and I very much thank you for participating. I would like to acknowledge the Confucius Institute Bremen and Hanban for also making this possible as my contribution today. And yeah, thank you very much for your input. I hope that all questions are answered for now. If not, then please write us an email, and then we are looking forward to further collaboration. Thank you very much. And I hand over back to you, Chen Gan.
Thank you very much for your participation. I think the time is up now. And we will wait for your further response if you would like to send emails to us. Thank you so much. So bye-bye.